us on this program. This is a recorded session. Again, I'm Debbie Studnitzer from Rockland Teacher Center. I want to thank all of the people that have signed up to take this training. This was actually a request from one of the nurses, the school nurses we received, and we contacted Sandra Aravallo from Nyack Hospital, Montefiore, and she has arranged that Jenna Kelly will present this topic to you. So I welcome you. I remind you that after the session, you should go back into my learning plan and complete the evaluation. And then once we have the attendance list from Jenna, we will be able to confirm your attendance at this professional learning opportunity. Again, thank you for being here. Thank you to Nyack Hospital. Thank you to Sandra, and thank you to Jenna Kelly, who is presenting.
Okay, great. Thank you, Deborah, and thank you all for attending. So just a little background about me. My name is Jenna Kelly. I am a certified diabetes care and educational specialist. I'm also a registered nurse for just over 20 years, and I've been here at Montefiore Nyack Hospital for just about 5 years, doing the diabetes education with inpatient staff members, that kind of thing. And before that, which is why I think I was chosen to do this topic, I was in a pediatric endocrinology office for almost 18 years. So I probably have spoken to many of you school nurses on the phone if you've been a school nurse for quite some time. It was a big endocrinology practice in Westchester. So today what we're going to talk about will mainly focus on type 1 diabetes, but it is really the diabetes care tests at school. So what you need to know to be able to help those patients, students with diabetes. So right now I'm just going to turn you over to my screen. Hopefully this works. And I think we're up. Okay, and slideshow. 1 second. Okay, is everybody seeing that screen?
Yes, we can see.
Okay, wonderful. Okay, all right, and can you still see me in the corner?
Yes, I can.
Okay.
I assume everyone else can.
Okay, wonderful. Okay. Okay, and just one more thing.
If there's any problems, please note in the chat.
Yes, please, exactly. And just also to let you know about the chat, certainly what we'll be doing is I'll address all the Q&A or the chat questions at the end of the symposium, okay? So diabetes. So obviously there are many types of diabetes. We have type 1, we have type 2, and of course we have gestational diabetes. Type 1, a quick overview. This is basically what you're going to be seeing in your schools. Type 1 diabetes used to be known as juvenile diabetes. I think about maybe 10, 15 years ago, they turned around and said, well, it's not juvenile diabetes anymore, because what we were seeing were a lot of people getting diabetes later in life. Actually, even last week, we had here in the hospital a patient who was in her 70s who wound up with type 1 diabetes. So we are certainly seeing this more and more most recently. What is type 1 diabetes? This is the type of diabetes where the body does not produce any insulin. So in order for the person to survive, they need insulin injections. They need insulin from an outside source to remove the sugar from their bloodstream and get it into the body so that your body can use it for energy. Without sugar in the body, you would have no energy. So a lot of people often think, well, you know, I have diabetes, I have so much sugar in my bloodstream, you know, why don't I have energy? It's because it's literally stuck in your bloodstream and can't get to the rest of your body, your muscle tissue, your brain, anything to function. So certainly type 1 diabetes is just basically your pancreas just stops producing insulin completely. This is, next slide is just a little information about type 1 diabetes. And this is just, I found it interesting. An average sized person weighing 70 kilograms, about 150 pounds, would require a transplant of 1 million islet cells. And that winds up being equal to 2 donors' islet cells. So people say, well, if islet cells work to cure type 1 diabetes or get your pancreas making insulin again, why don't more people do it? Studies have shown that in type 1 diabetes, a year after the transplant happens, that only about 40% of people can remain off insulin. So also the participants who actually have had this surgery performed generally have to go on a lot of autoimmune and medications, and makes them more susceptible to everything else out there. And especially with COVID, diabetes doesn't seem so bad to require a few shots a day. Only 1 to 2% of the pancreas is made up of these islet cells. And another fact, just according to the American Diabetes Association, type 1 just accounts for about 5 to 10% of those people diagnosed with diabetes. Caucasians, white people, have a higher risk of type 1 diabetes than any other race. We're not sure whether this is environmental or whether it has to do with genetics. Type 2 diabetes is, yes, the big population of what makes up diabetes. This makes up for about 90 to 95% of people with diabetes. It usually develops in patients over age 45, but guess what? We are seeing it younger and younger. Even years ago when I was in my pediatric office, we kept seeing more and more patients come in with type 2 diabetes. Why? Obesity is a huge issue. Certainly, that's all I see walking around. You see kids walking around with their iPad or their Nintendo Switch, and they're less and less active than they used to be. So what can we, as the school health professional, tell parents who have patients with diabetes or children in general? Drinking more water is certainly going to be helpful. Avoiding the sugary drinks or limiting them. Eating more fruits and vegetables. Just including healthier foods, and obviously the number one, getting out there and being physically active. I know right now my daughter is virtually learning at home, and certainly gym class is not what it used to be. So you know, trying to get them out after school is over and outside, especially while the weather's still nice, will help. Again, another statement here just talks about 75% of children with type 2 diabetes have a close relative with it, but it's unknown whether this is from genetics or it's because of the habits they share. You know, families that are eating together or on the run and not eating the proper foods and constantly eating these fast foods and packaged foods and that kind of thing are certainly putting us more and more at risk, especially with our pediatric population. Again, this just talks about insulin. This is a picture of our little pancreas right here. It shows us our beta cells and how they react. Insulin is in fact a hormone, and it is manufactured from the beta cells. Every time our meal is consumed, our beta cells then react and start making insulin. With type 1 diabetes, however, this is not the case. They've been destroyed, whether it's an autoimmune response or for some other reason, they're not going to make the insulin anymore. So what does our body then require? Insulin injections. This slide just talks about that insulin cannot be taken in a pill form. Wouldn't that be lovely? We would probably have a lot more compliance with people with diabetes. If it were consumed orally, it would basically break down in your stomach, just like normal proteins in your food. So insulin must be injected into the fat under your skin in order for it to get into your bloodstream. Inhaled insulin, right? We said you can't get insulin in a pill, but how about breathing it in? So inhaled insulin kind of came about in the 1990s when researchers were researching this. They realized that many patients can use this inhaler form, especially type 1 people with diabetes. And in June of 2014, the FDA approved Afrezza. It's an inhaler with pre-measured rapid-acting insulin you use before meals. So people say, well, why wouldn't everyone, what did I just do? Here we go. Oh, no. I'm sorry. Okay. Why wouldn't everyone just use inhaled insulin? Well, you still need long-acting insulin. The rapid-acting insulin, and I'm sure many of you know this when you have your patients or students at school, right? They're taking their fast-acting, their rapid-acting insulin before the breakfast. If they're coming to school early, they're taking it at lunchtime, and they're also taking it if they attend an after-school activity or to cover their high blood sugars during the day. So this basically would just, eliminate 1 or 2 shots during the day, as opposed to, what's the difference? Inhaled insulin also is affected by lung disease, asthma, COPD. So it's not going to work as effectively, and it's also in the inhaled form a lot harder to dose. And that's why they say here for patients who are experiencing ketoacidosis or DKA, you should be using it. Okay. So that's kind of diabetes. So those were my slides. I'm going to talk to you a little bit now about hyperglycemia, right? What diabetes is. And the next few slides are certainly put out by the American Diabetes Association. So again, managing hyperglycemia, it's a vital piece of our comprehensive plan. We certainly want to prepare the school nurse and school personnel to perform diabetes care tasks. This will ensure that the health needs are addressed in times and locations when a nurse is not available. So the school nurse, when she is or he is available, is the most appropriate person in the school setting to provide the care for the student with diabetes. However, many schools, right, which I'm sure you can all state yourself, don't have that many nurses, or have enough time to get to every single patient in a timely manner every time something is needed. So even for the school nurse, the school nurse may not always be available during the school day, during school-sponsored activities when they do start up again, or field trips to assist with this routine care and emergency care. So that's why we also need trained school personnel available to perform and assist the students with diabetes. Okay, so here we're going to talk about the learning objectives. Again, what are we going to be able to understand? Symptoms of high blood glucose, treatment of high blood glucose, reducing the risk of high blood glucose, and the short and long-term, risks and complications. So vocabulary, this is very simple vocabulary when it comes to diabetes. Hyperglycemia, right? That's too high of a blood glucose. Your medical management plan in the school will certainly tell us what exactly your student or their parents and their health professional considers hyperglycemia. Some parents would say a hyperglycemia is at 250, while others say, okay, 300, this is when we call it a hyperglycemic episode. Ketones are chemicals that the body makes when there is not enough insulin in the blood, and the body must break down fat for energy. Diabetic ketoacidosis, it's an acute metabolic complication of diabetes, which is characterized by excess acid in the blood, which can be life-threatening. I'm sure many of you have done the urine test to test and see if your patients did have any ketones or were either in diabetic ketoacidosis or on their way, and I'm going to talk about ketone testing a little bit later. But again, that's the procedure for measuring the level of ketones in the urine or blood. Most patients do just test the urine. The blood test strips are pretty expensive. I think even with health insurance, they wind up costing like $5 a test strip, to perform this on a blood glucose machine. And simply glucose, right? That's our simple sugar found in the blood and the fuel that all body cells need to function. I always like to tell people, you know, what is diabetes? What is hyperglycemia? When I do my patient training here in the hospital and I'm telling patients what diabetes is for the first time, I always say, well, picture this. Picture yourself eating a slice of pizza. We eat the slice of pizza, it goes down our esophagus. From our esophagus, it gets into our stomach, and here it's the stomach acids that start breaking down the food and turning most of the foods we eat into sugar, a glucose form, or proteins, and all the other vitamins and minerals. So once they're formed into what we can absorb into our body, it's then sent out into our intestines. And it's here that the intestines send the protein, the vitamins, the glucose, right, into our bloodstream. Again, what diabetes is diabetes is high sugar in our bloodstream. And normally what happens when your body realizes that there's all this excess sugar coming in, your pancreas, right, that those beta cells stimulate and start sending out the insulin to kind of wrap itself around the sugar and pull it out of your bloodstream into the cells for energy. And here, this is diabetes. This is not happening, especially in type 1. In type 2 diabetes, the body is still making insulin. It's just that connection between the insulin and the glucose is not happening as quickly. The body can be resistant to it, or your body's just not making enough to keep up with what you're eating. So high blood sugar, right? It's usually slow to develop. You know, it can occur more rapidly in students with insulin pumps, okay, if an insulin pump is malfunctioning or delivering less insulin. Why? Insulin pumps work by administering subcutaneously insulin when it's needed, right? So it constantly has this basal rate background set, and it also will deliver insulin on demand in bolus doses. And I'll get into that later. But what it is using is it's using this rapid acting insulin. So we all know that rapid acting insulin, right, starts working in about 10-15 minutes, right? That's why we have to make sure when our student's eating something and we've given them insulin that they are going to start eating pretty much right away. But with an insulin pump, right, if we have a malfunction, we have a clog in the line, we have a disconnect, we have that, you know, the cannula bent under the skin and they're not getting this insulin anymore, what can happen is, right, we can wind up going into high blood sugars pretty quickly, as well as diabetic ketoacidosis, because after about 4 to 6 hours, probably more on the 4-hour side, our body has no insulin left in it. And that's when, you know, we're going to see this greatest danger for diabetic ketoacidosis. Any student who with diabetes who presents to you in the nurse's office with flu-like symptoms, right, we should immediately perform a blood glucose check, right? Because a lot of what we see with diabetes exhibits flu-like symptoms. Your diabetes medical management plan should specify signs and actions to take at each level of severity. There's obviously mild, moderate, and severe, and it's important to know the difference between which one. So this is just a slide. It talks a little briefly about mild symptoms, right? The biggest ones we all know, right? The student comes to you thirsty, or they have to use the bathroom frequently. Those are the 2 major signs that a patient's gonna exhibit that says, okay, I think my blood sugar's high. Blurry vision, sure, if they're complaining of not being able to see the smart board or chalkboard or whatever that you guys are using now, and fatigue and sleepiness. You know, if a patient's having a hard time concentrating at their desk, it certainly could be either hyperglycemia or hypoglycemia. So if they have any of these symptoms at all, we certainly want to check. Our moderate symptoms include, right, dry mouth, vomiting, stomach cramps, nausea, right? if your patient or student is certainly having any nausea or vomiting, you're probably on your way to DKA and are probably having ketones in the urine, okay? These are just signs of the body trying to get rid of all this excess sugar. And you're going to see this with vomiting and nausea. Severe symptoms are labored breathing or confusion, right? These are big ones. If we're seeing this, I can almost promise you that patient's in DKA, and that's a severe medical emergency. So again, hyperglycemia, if untreated, can lead to DKA. It will interfere with the student's ability to learn and participate. Certainly learning when you feel sluggish or nauseous or on the verge of vomiting is not going to be as great as if a patient feels fine. There are serious long-term complications. Diabetes is the leading cause of adult blindness, lower limb amputations, kidney failure, heart disease, and stroke. And oftentimes our kids aren't thinking about this. I can remember going into so many patient exam rooms for follow-up visits, and children generally feel that they are warriors or don't have any other anything to worry about, and certainly much later we're going to see the complications. So we want to stay ahead of it. We want to make sure that we teach them that treating the high glucose levels with the DMMP plan and following the doctor's orders will allow these children to participate fully in their education, their sports. There's nothing that someone who has diabetes can't do in the school. Our goals for hyperglycemia, right? Obviously, we want to lower the blood sugar to target range. Action steps following the plan, right? If we think the blood sugar's high, we want to verify it with a blood sugar. If the blood sugar is high enough, and again, some people check ketones at a blood sugar of 250, others check at 300, some wait until there's 2 above 300 in a row. That, again, is all in the diabetes management plan. And again, we just want to make sure we stay on top of ketones, especially because it could lead to something life-threatening. We always want to allow the children to use the bathroom and access to water to help get rid of all that excess sugar in their urine, and administer insulin when needed. And again, this is all part of the diabetes medical management plan. Calling the parent guardian, yes, great. They should be aware of what's going on, especially if these numbers are critically high or critically low. And certainly we want to be part of this by helping the families by communicating with the parent, what was Johnny Smith's day like? What was his blood sugar at snack time, and what about lunchtime, and were there any other issues? So what are some possible causes of high blood sugar? Well, the first 4 items in the list are the main ones, right? That's we administered insulin too late or completely forgot to give. Our food intake exceeded insulin coverage, right? So oftentimes, these patients or students with diabetes know how to cover their carbohydrates. They know how to carbohydrate count, but sometimes they're off. And guess what? When they're off and they underestimate their carbohydrates, or they ate something maybe they shouldn't have, you're certainly going to have a high blood sugar later on. Decreased physical activity, right? So the days that it's raining out, when they eventually again go back to school, if they're sitting in a classroom because rain, snow, cold weather, you might see a high blood sugar later on that afternoon. The next few, expired or improperly stored insulins. Yeah, I mean, the insulin that we're using, is good for 28 days usually. Most kids that are in school have Humalog or Novolog insulin, the fast-acting insulin there. And certainly the vials are kept in the fridge, whereas the insulin pens are certainly just kept in hopefully a locked cabinet, or a cabinet certainly that the other children can't get out to, but everyone knows where the emergency supplies are in the school. So High blood sugar, illness, injury, stress, other hormones or medications can certainly make the blood sugars go up. Hormone fluctuations, including menstrual periods, sure. Not only menstrual periods, but when we have students having growth spurts, right? At that age of 12 to 16, blood sugars become erratic for these kids. And again, any combination of the above. So preventing of highs, how do we prevent highs, right? Timing, it's important. Try and keep to a schedule. Keep meal times the same, the insulin administration appropriate, and physical activity. If we have more consistency with this, we're going to have more consistency with our numbers. Accuracy is important, right? We're not seeing very well when we're trying to drop in a vial syringe, which I don't believe many kids are doing anymore. We want to make sure that whoever's dosing and making sure that we're doing everything correctly, counting the amount of carbs and accurately doing the math equation for that. Obviously, changes should be made after speaking with the parents or guardians if we feel that something needs adjustment, right? If we realize that every day after morning snack and before lunchtime, we're having a dip in our blood sugars, certainly we want to make some changes to the diabetes medical management plan to either make changes in their carb ratios or the insulin that they're getting at breakfast or whatever's going to help. And obviously that would be up to the parents or the physician of the patient. Okay, ketones. Ketones, right, are basically acids that result when the body doesn't have enough insulin and uses fat for energy. It's basically the byproduct of your body, right? Just remember this, your body, when we have diabetes and we have the high sugars and we don't have any insulin left in the body, right? Remember this, that blood sugar is going to keep building and building and building in our bloodstream. So when it keeps building in our bloodstream and it can't get to the cells it needs for energy, your body thinks it's doing something good. Your body says, okay, well, we don't have sugar to burn for energy. Let's start burning fat. And when your body starts burning fat, all the acids start forming. And that's why we get a lot of times, often people, you saw earlier in the last slide that talked about oftentimes people have the Kussmaul breaths, right? That the labored breathing, right? That's our acids are off. A lot of times the potassium, the sodium levels go off when we wind up in this DKA, and it can throw off the rhythm of our heart, and really it can do some damage. So ketones, we don't like them. Ketones also make it very hard for your body to use the insulin once we start getting it back on board. So again, when can it occur? It can occur if we skip the insulin dose, right? We talked about earlier, if we have a pump malfunction or we have an issue with the pump getting the insulin into our body. If we're under stress, and even with dehydration. So we always want to make sure anyone with diabetes, we certainly want to keep them hydrated. It certainly can cause abdominal pain, nausea, vomiting. If you're at the vomiting stage, right, it's going to be a lot harder to take in liquids, meaning sugar-free fluids, most likely water. And it's the rehydration as well as insulin that's going to help get rid of these ketones before we wind up in this DKA state. Okay, so why check for ketones? Again, it's a critical emergency state, right? These patients that show up in the hospital in DKA, they're going into our intensive care units, and they're getting hooked up to IVs and they're getting put on insulin drips. So it's important to detect ketones quickly, because at a lower stage of ketones, we can certainly get a grasp on this at home before we wind up in DKA and have to get hospitalized. Untreated progression DKA can lead to severe dehydration, coma, permanent brain damage, and death, which again, we see too often. So it's just very important, especially with our patients with type 1 diabetes, where we know their body is not making any insulin. We skip insulin, right? Even that long-acting insulin, and then a breakfast dose, we could wind up in DKA pretty quickly. DKA is the #1 reason for hospitalization in children with diabetes. So we certainly don't want that. When should ketones be checked? When the glucose remains elevated, right? Like I said, the one doctor's office that I worked in, anytime the blood sugar was greater than 250, 2 in a row, we were asking them to check for ketones. Again, it's part of your medical management plan. So if it says 1 blood sugar over 300, certainly do it then, or 2 over 300. That's when we're going to see ketones. During acute illness, hopefully they're not in your care and they're at home with their parents. But infections, that's another thing I used to see all the time in the pediatric practice was some of these patients would wear their insulin pumps, and on the 2 or 3 day change when they were supposed to change their sets, they were leaving them on for a week. They were winding up with infections that were pussing, and that alone was causing the blood sugars to get high. And then of course the insulin, right, was not getting through that infected area. So we just want to be on the lookout, make sure, we're doing everything we can to avoid DKA. So whenever any of the symptoms of DKA are present, we should check for ketones. If the patient comes in nauseous, vomiting, diarrhea, abdominal pain, or fruity breath, we want to check. Okay, so how quickly does DKA progress? Again, we were just talking about this. It usually takes hours or even days to progress, but our patients who are on insulin pumps, and as great as they are, and I love them, we can wind up in trouble pretty quickly. Patients who are most at risk when symptoms of DKA are mistaken for flu or something else, or if the blood sugars aren't checked. And we'll see this in the high school student who says, I got this, I don't need to come in, or I'll just verbally tell you what my blood sugar is. So we certainly want to make sure we're keeping an eye on things. There's a lot of technology out there that will help us, and I'll get into the technology a little later on. Checking the urine for ketones. If you're a school nurse, I'm sure you've done this, right? Obviously, we want to put on gloves. We dip the ketone test strip into the cup of urine. We wait, generally speaking, most of these tests are waiting 15 seconds, and then we're reading it. Here on the screen, when should we panic? Those moderate large ketones, right? That's we're either in DKA or we're almost there. At negative ketones, that's great, right? Some ketone test strips test both ketones and glucose, while others just test ketone. The glucose on anyone who has a high blood sugar will be all the way at the end. It will be at the highest level. And then when the glucose gets to the highest level, that's when you're going to start seeing the ketones read. So it'll start out with negative, trace, small, moderate, and large. Trace and small, you can still work on that. Trace and small, it's pushing the sugar-free fluids. We've always said 8 ounces at least every hour, plus giving that insulin, because the fluids alone is not going to get rid of it. We need to get the insulin on board to get that sugar out of the bloodstream. Okay, that's ketones. Okay, we're all the way up to hypoglycemia, okay, right? The opposite of diabetes. So what is hypoglycemia? Again, we're managing hypoglycemia. It's an important part of the plan. Some key learning objectives, symptoms of low blood sugar. We're going to talk about the treatment, reducing the risk, and short and long-term complications. Our key words, right? Glucose, we already went through this. I think by now we all know what glucose is. Hypoglycemia, yeah, it's a low level of glucose in the blood. Most people define hypoglycemia as a blood sugar less than 70. And then a critical blood sugar is generally speaking known as a blood sugar less than 54. But oftentimes people consider a critical low blood sugar less than 60. Quick acting glucose, right? That's our simple sugar source. So this is what we're going to use to raise that blood sugar if we've gotten it too low. Fruit juice, apple juice, orange juice, regular soda, glucose tablets, gel, hard candy, right? Skittles, Lifesavers, that kind of thing. Those are quick acting sugars that's going to work the best to get our blood sugar back up to normal. There's also things like glucose tablets or gels. What they are, these are special products that deliver a pre-measured amount of glucose. They're great. A lot of times they make the glucose tablets in a little container that has like about 8 or 10 of them in there that the student can keep in their school, you know, in their pocket, so that if they do feel low and they don't have access to the glucometer, they certainly can use it, or just have it readily available for when they do check and it is low. Carbohydrate, this contains both simple and complex carbohydrates. So carbohydrates, they're the source of energy that raise blood glucose levels, right? Simple would be our fastest acting ones, our juice, or you know, every juice, soda, glucose tablets, those are the fast ones. The complex carbohydrates are our starches, our starchy foods, our potatoes, our rice, our pasta, that kind of thing, which eventually in the stomach will turn into sugar. And then obviously glucagon. It's a hormone given, this is by injection, but I added a couple more slides because technology has given us a few more options. And glucagon is basically what we give ourselves when we're having a low blood sugar to help raise it. Okay, so hypoglycemia. Hypoglycemia is, right, something that we need to treat immediately. The medical management plan that you have should specify these signs and actions to take for each student and at each level of severity of hypoglycemia. There's, right, we just talked about mild level, level 1, which is a blood sugar less than 70. Moderate level 2, where the blood sugar is less than 54, and what makes it level 3? If we have cognitive impairment, right? If we have jittery, you know, arms, legs, if we can't certainly speak, you know, we certainly then know that this is more serious than our moderate level. So, early recognition and intervention can prevent an emergency from happening, right? The greatest immediate danger is from hypoglycemia, because yes, pretty quickly you can deteriorate, a lot quicker than you can with a hyperglycemia. Hypoglycemia is not always preventable, and yes, it does impair the cognitive and motor function of the student. So most episodes of hypoglycemia are mild. Most students will respond to eating quick-acting carbohydrates, such as fruit juice or regular soda, within about 10-15 minutes. So we always want to make sure that, again, like I said, whether it's a student carrying the glucose tablets around, that there's always something, food or juice or something around to prevent the emergency from going further. Hypoglycemia is the greatest immediate danger to students. Most often students will be able to recognize and treat their early symptoms themselves. Occasionally though, a student might miss the early symptoms, right? They might just think, oh, I was up all last night studying for a test, I'm tired, I'm yawning, or it happens so quickly that they can't even rely on themselves. I myself have type 1 diabetes, and I can remember in high school, I was the carpool, a part of a carpool. My brother was with me, and it was my turn to drive, and we were walking out the door, and it was a winter day. I had a cup of hot cocoa, and I kept spilling it on the floor. And he said, you know, what's wrong with you, Johnny? He'd pick it up, handed it back to me. And then he said, well, what are you slipping in? I kept falling and collapsing, but it was unrecognizable. Why? I woke up, I checked my blood sugar as I normally did. You know, it was 80 or 90 or something. It was a pretty good number. For whatever reason, my blood sugar dropped, and I didn't recognize the symptoms. And even my brother, you know, had a hard time recognizing the symptoms because it was so out of the normal. So we need to depend on other people sometimes to recognize when they are having a low blood sugar, because again, we don't want to lead to unconsciousness, seizures, or anything else that might be life-threatening, coma, right? The motor function part, right? Even a student who needs or knows that he or she might need to eat might not be able to problem solve in the event when they're so low, right? They're thinking that they can't think. There's not enough sugar going to their brain to think. So always be aware too that these students can become combative, and it can be mistaken for misbehavior. Hypoglycemia, what causes hypoglycemia, right? It occurs when there's too much insulin in the body, right? So the imbalance can happen for 3 main reasons. Too much insulin's been administered, too little food has been eaten, right? Or extra or unexplained physical activity. The rest, maybe, you know, illness and stress usually cause the blood sugars to go up. But again, if we're ill and we're not eating anything, our blood sugars certainly can plummet, especially if we've taken morning insulin. You know, a student may have gotten too little food for a variety of different reasons. They may not have finished their meal of snack because they ran out of time. They may have, again, miscalculated their carbohydrates and overestimated these, or the meal may have been skipped altogether. So again, no restrictions on physical activity for students with diabetes, but when a student is more active than usual, especially at insulin peak times, they may experience low blood sugars. So possible signs and symptoms of low blood sugar, right? I'm sure many of you have seen all these, right? The sweating is a big one, confusion, irritability, dizziness, paleness, weakness, shakiness, irritability, frustration, right? The sudden crying for no reason. Again, most of these, you know, there's a whole list here. I don't know how many are there, the 15, 20 of them. The student knows the signs that they usually get, and so will the parent. So certainly in the diabetes medical management plan, you want to sit down with the parent and say, hey, what are the common signs that they get for low blood sugar? Because more often than not, they're the same ones. Severe symptoms, right? If they're not able to eat or drink, they become unconscious, unresponsive, they're having these jerky movements, right? It's certainly scary for you and scarier for them. So we certainly want to make sure that everything here is listed in that medical management plan. So what do we want to do? We want to make sure that we are treating this pretty quickly, right? We want to follow the DMMP. Not a bad thing to memorize this one, especially because when it happens, you want to think quick. Obviously, we want to see if the glucometer is available. If it's not, we always treat as a low. We'd rather have you have a high blood sugar, you know, a half an hour from now than be unconscious or be in big trouble. So again, if the glucometer is available or you can get to it, certainly do it. If you can't, then just treat it as if it were a low blood sugar. And again, we never ever want to send a student with a suspected low blood glucose anywhere alone. Again, your DMMP is going to specify the treatment, and this is our lovely rule of 15, right? I'm sure all of you know this, right? The rule of 15 is basically we check the blood sugar is less than 70, right? Or whatever stated in your medical management plan. We want the student to eat or drink that fast-acting carbohydrate, right? Like 15 grams of sugar, half a cup of fruit juice or regular soda, right? A handful of Lifesavers. We want to then recheck that blood sugar 15 minutes later, because guess what? When we're just pouring straight sugar into our body, that sugar is going to raise in 10, 15 minutes. We also want to make sure, which I've seen a lot of times, you know, the student gets treated for the low blood sugar with a cup of juice, and 5 minutes after they finish the cup of juice, they're having a small snack, the crackers, the cheese. Well, guess what? Now you're putting that into your stomach on top of the juice, and your stomach then starts breaking down that cheese, the crackers at the same time. And so your blood sugar is not going to go up as quickly because your stomach starts breaking down the other stuff, and the sugar then cannot get released into your intestines and out to your bloodstream. So you always want to make sure we're just treating with this 15 grams of fast-acting carbohydrate right away, and we're following up with a recheck, right? If that recheck is still low, we want to retreat, and we want to keep doing this with the fruit juice, the soda, until we finally get that blood sugar back to normal. You know, oftentimes the DMMP will say until it's above 70, or it'll say no, at this point we want it above 80. Again, that's determined by you and the parents when you're putting that together. Again, here's our treatments. Yeah, half a cup of juice, 3 to 4 glucose tablets, a tube of glucogel, 4 to 6 hard candies, right? These are all different ways to treat. Oh, the last one I have to go back on, because how many times I've heard some people have just given that 4 teaspoons of table sugar. Please put this in water first. I don't know if you've ever seen anybody try and do the sugar packet thing and take it that way. I promise you they're going to start choking. So you certainly want to make sure that you dilute that with water. So severe hypoglycemia, this is the inability to swallow, eat, drink. This is unconsciousness, unresponsiveness, convulsions. Students should respond to the glucose in about 10 to 20 minutes. If they don't, obviously we want to keep retreating. When the student is awake and able to swallow, we always want to try and give the juice first. Again, if the patient is not treated properly, we're going to wind up in big trouble. So if they do become unconscious, the first thing we want to do is place their student on the side, right? We lift their chin back to keep their airway open, and then we're going to use the glucagon. We never ever want to put food in their mouth, right, as a choking hazard. We want to call 911, and we want to obviously stay with the student until you know, help arrives. Prevention of lows, right? The best way to do it, right? We want to watch when they're physically active. We want to also make sure we're monitoring the amount of insulin they're getting and that it's consistent with what they're eating, and they're checking their blood sugars. We always want that quick acting carbohydrate with the student, and ensure that we are dosing the insulin correctly. These are just some helpful tips, right? We want to ensure that insulin dosing matches the food eating. So watch out for picky eaters. Oftentimes, and I talk about it a little later on, we sometimes like to give these patients insulin after they've eaten, just to make sure that we're going to cover it appropriately. And I've seen with insulin pump patients, oftentimes they'll give half up front, and depending on how much they eat, they give the remaining half later. A few more prevention strategies, right? Changes in the time of snacks, meals, physical activity, it should only be made when the parent or guardian or healthcare provider has stated this. Checking blood sugars of the variations that might happen on gym days, or giving an extra snack, you know, a half an hour before gym to stop the low blood sugar from happening often works. And again, we never want to let that student be alone. We always want to make sure that when the low blood sugar is suspected, that there is adult supervision there. We never want to rely on the student with diabetes for their management information. Again, we want to go back to that DMMP, and hopefully, like I said, with low blood sugar, you've memorized this. Often, you know, kids with diabetes seem like experts on their disease, but they do have limits, especially when their blood sugars are low and they're not thinking correctly. Information for teachers, right? Yeah, if they're having high or low blood sugar, they're not concentrating well. They should be allowed adequate time for taking their medications, checking the blood glucose, and eating if it is during testing time. And we want to follow the academic testing and allow for the accommodations for the 504 plans, which is what I know, because this DMMP, I feel like I wasn't filling out those forms. It must have been the parents, but I certainly wrote my fair share of 504 plans. So we want to make sure that they have access to food and drink, they're checking their blood sugars during testing, and if a seriously high or low blood glucose episode occurs, they should be excused with an opportunity to retake their tests. Eliminate barriers that are gonna make us have a low blood sugar, right? So we wanna make sure that they don't have any issues when it comes to snacking or checking their sugar or using the bathroom or even insulin administration. We wanna become very familiar with their 504 plan, and we wanna make sure that we're constantly communicating with the parent or guardian. Okay, this next slide is a video. Yay for me, I get to take a break and a sip of drink. But this is the medical management plan, and I felt like you guys certainly know about the medical management plan a lot better than I do. It's a quick 3-minute video, so here we go. And let me just see if I can get this over. Hang on one sec.
Plan. As you all know, the Americans with Disabilities Act, Section 504 of the Rehabilitation Act, and the Individuals with Disabilities Education Act all provide protections to people.
You can't see it?
No, we can hear it, but we can't see it.
These federal laws ensure equal access to school-sponsored activities. Students may not be shut out of any school activity because of their diabetes, and they are entitled to a medically safe
There we go.
environment.
Sorry about that.
Which laws apply depend upon both
Can you
the
see it
type
now?
of school the student goes to and
Yes.
how diabetes affects
Okay,
him
great.
or her. State laws also need to be taken into consideration in determining, for example, who does what task, but the bottom line is that students must get the services they are entitled to at school, and parents cannot be required to come to school to provide care. Once a student has been diagnosed with diabetes and found to be protected by one or more of these laws, school staff and family need to take the next step and write a 504 plan or an individualized education program, or IEP. That explains how the student's diabetes medical management plan will be implemented in the school setting. This plan gives all the details of how the student's diabetes will be managed in the school setting. The school, the student, and the parents all need to be on the same page. They need to know where and when the student should check blood glucose, and whether the student needs help in doing so. Who at the school is trained in diabetes management? That includes the school nurse and other school staff who give care if a nurse is not available. Where diabetes supplies are kept. The student should have free access to water and restrooms. The student's nutritional needs for meals, snacks, and special events like parties, and how food is going to be handled. The student has a right to alternate times for exams if he or she is experiencing low or high blood glucose. The student should not be penalized for absences for doctor's appointments or prolonged illness. The student with diabetes should be safe on field trips and all school-sponsored events. Wherever the student is, diabetes supplies and trained staff need to be there too.
Okay. Okay, can you see my screen again? Oh, there's me.
Yeah, you.
Okay, I'm coming. Okay. Okay, can you see my screen now?
Yes, we can see it.
Okay. Okay, so this is glucagon administration. I'm going to kind of speed this up because I see I'm taking a little longer than I expected. Again, what glucagon is, right? Right, it's the naturally occurring hormone made in the pancreas. It's a life-saving hormone that raises blood glucose levels by stimulating the liver to release stored glucose. It's usually injectable. Right now they came out with some new nasal administration of it. And this is what we use for hypoglycemia. Storage, right? It's got to be accessible to all school health professionals. This is probably the oldest one that we know that's been around forever. What it is basically this is glucagon. In this little vial is the freeze-dried glucagon, and in the syringe is just a milliliter of sterile water for reconstitution. We don't want to pre-mix this. When do we want to use this? Right, for the unconscious, unresponsive person, patient who's exhibiting convulsions, or if we have an inability to eat or drink. Again, we want to act immediately. If possible, we check for the blood glucose. If not, always treat. We always want to make sure that we position the student safely on their side to protect them from injury. And we need to obviously give that glucagon, and once the glucagon's given, call 911. Again, to prepare it, all we're doing, we're flipping the cap off that glass container of the dried powder. We want to put on gloves if available. We want to use an alcohol swab if available, but if none of those are available and we need to think quick and act quick, we want to inject that sterile water right into the vial of powder. We want to shake it or mix it. We don't want to shake it too much that we're winding up with bubbles, but we certainly want to make sure we get that white powder off the sides of the glass and into the solution. When we look at the solution, it should be clear and colorless. If you're still seeing flakes of white powder, it's not mixed properly. Again, we're not, going to sit here and spend all day long trying to make sure that we've gotten every little last bit of, powder off the sides, but we want to make sure that there's enough in there to treat. So we want to draw up the prescribed amount of glucagon. For each student, this is different depending on how much the student weighs. Generally speaking, if the student weighs 45 to 50 pounds, they're given half a milligram, which is half the dose of the solution. Whereas if they are above 45, 50 pounds, they're giving the full dose, the adult dose. We always want to clean the site if possible and inject at a 90-degree angle. So basically straight in. Why? This injection has to go into muscle. So we want to make sure that needle tip is getting all the way through the fat tissue and into the muscle. Again, right, we're preparing, we're making sure the patient's on their side, and we're injecting. Inhaled glucagon, this is fairly new. This probably came out, I don't know, maybe a year ago. It's a dry nasal powder. We don't have to be able to inhale, right? It's not like it's an asthma inhaler where we need to suck in, right? So if the patient's unconscious, we can still use this. It is a fixed dose. It's ready to use. The next slide just shows you how to hold it, right? We obviously unwrap it. We hold it between our two fingers, and we insert this into our nostril. The two fingers, the finger depth is how we know it's in correct placement. So when the top of our finger touches the outside of the nose, we know we're in far enough. And then all we're doing is pushing the plunger on the bottom there in, and then we're letting the plunger come back out. And we'll know this because that green line will have disappeared. This is great. This is, like I said, it's fairly new. And something certainly that should be used in the school system now. There's also the same rules follows for this treatment with the glucagon as it does for the injectable. We always want to make sure that we're treating it right immediately. We're calling 911, and that we're obviously waiting around for the patient to come back. If for some reason 15, 20 minutes later, the patient is still unconscious and we're still waiting for that, ambulance or paramedic to get there, we certainly want to give that glucagon again. This last one is one that came out became popular a couple months ago. This is a premixed pen. It works much like our EpiPens. It's called the Gvoke, or some people call it the Gvoke. But what it does is, like I said, it works like an EpiPen. Difference here is that this is subcutaneous injection. So this certainly is not one that you can give through clothing like you could with the other intramuscular ones, right? We always said if you found somebody unconscious and you had to think quick, you can give that injection through the pants, through the shirt, that kind of thing. This pen, though, because it is a subcutaneous injection, you definitely need to administer this to skin directly. With all of them, right, this could take 10 to 20 minutes. We want to check the blood glucose. When they do come around, we want to start giving them sugar, the fruit juice, the regular soda. And then obviously advance the diet is tolerated, right? When they are feeling better, when that blood sugar is above whatever is stated in their DMMP, whether it's 70 or 80, we want to make sure that we start giving them a small snack. Okay, don't be surprised, right, if the student doesn't remember what happened. Oftentimes they don't. They have no clue what just happened or what led up to it. Blood glucose becomes very high. That is definitely often seen. I can remember my fair share of blood sugars going into the 300 and even 400s post-glucagon. Hopefully at this point, the parent is coming to pick the child up and we're not trying to send them back to class. And also we can many times see that nausea or vomiting occur, right? That sugar surge certainly will make them feel pretty bad. Diabetes and alcohol, I added this in because I know now more often than we'd like to think our high school students are drinking and doing other things. Why I teamed this up with the glucagon is because what I'm basically going to tell you. So drinking alcohol can lead to low blood sugars if you take insulin, right? If you have no carbohydrates or foods digesting, then you're relying on your liver to make and release glucose. Oftentimes people don't realize that our liver actually is sending out glucose into our bloodstream. Whether we're eating or not, this is why sometimes people have high blood sugars if they haven't eaten in a day or two, okay, and they have diabetes. But when we add alcohol into the system, especially with someone on insulin, the blood sugar can drop quickly. And people go, well, what does the blood sugar have to do with, the liver? Well, glucagon, right, might not work in a patient who has diabetes if they are drunk or they have alcohol in the system, because the glucagon hormone, right, that's in the injection or the inhaled device, right, glucagon, what it normally does is it stimulates the liver to send out the sugar. But what's happening in somebody who's drinking alcohol is that the liver is too busy processing the alcohol to actually even concentrate on sending sugar out. So each alcoholic beverage takes 1 to 1.5 hours to finish processing in the liver. So for that entire time, your risk of having a low blood sugar exists. Again, your body starts working on the alcohol and it forgets about releasing that sugar. So think of it this way, you have 2 drinks, now you're talking about 2 to 3 hours that you're at risk for low blood sugar, because what normally is happening, your body setting out that sugar no longer exists anymore. So the insulin that you've taken today that worked for you yesterday because you had no alcohol in your system is not going to be correctly adjusted now that your body is no longer sending out this sugar into your bloodstream. Okay? Again, anyone who has diabetes, we tell them never drink alcohol without having a carbohydrate, because guess what? You're going to wind up and bigger trouble a lot quicker. Okay, so continuous glucose monitoring. This is when I start talking about all our lovely medical devices that are out there and available for us. You know, we've come far. We've come far. We definitely should be further where we are by now, I feel like. I have had diabetes myself for 40 years, and I can remember 10 years into it, the doctor said, oh, we're going to have a cure in 10 years. Well, that was, you know, 30 years ago. So we're getting there. We're not exactly there, but we've certainly made big improvements, I would say, in the last 5 to 10 years. So a continuous glucose monitor, that's what everybody calls a CGM. We're going to talk about why it's used and when and how to use the CGM. So CGMs have 3 parts. They have what's considered a sensor, a transmitter, and a receiver, okay? The sensor, okay, that's the needle part that's injected underneath the skin. And this sensor is actually worn there for anywhere between 7 to 14 days. Some systems allow 7 days, some 10, some 14. The transmitter, right, that's that second part, is attached to the sensor. The transmitter is kind of like, I would call it the motherboard, right? This is the computer chip that's taking the information out of the sensor, the needle, and feeding it to the receiver. The receiver is great. Some people, some of the systems now don't even use a receiver anymore. They either use the insulin pump as the receiver of the information, or they use smartphones, which are great. It eliminates one more thing to carry around. These systems automatically record glucose values every 1 to 5 minutes, depending on which system it is. And some of them, most of the ones you'd see in pediatrics, provide alarms to signal when the glucose is out of range. Here we go. So these are my slides. I just thought it made it easier to understand what I'm talking about. So, right, the sensor, that's the needle tip. The transmitter, right, that's that little microchip that's reading the information to the receiver. And if you can see on the bottom left, that's a CGM system that's actually connected to an insulin pump. So you're actually getting the data right there in real time on the insulin pump screen. Here's a few other ones. Again, this one does not, well, in the picture, it's not being used with an insulin pump, although this sensor CGM device can be used with an insulin pump. Here it's used on a person standalone, and you can see there it is. It's working to their watch, their phone, and you can also have other users accept this information. So whether the school nurse wants this information at her desk or his desk is great. The parents also have it at home. I know for a while that some of the school nurses I talked to said, oh my gosh, the mother calls me every 10 minutes. Why? Because, you know, that she's seeing or he's seeing that the students' blood sugars are going up and down. So great technology. I know this picture is a little blown out, but I thought it was the simplest way to explain what the sensor is actually doing. The sensor is not that long of a needle, right? What it's measuring is interstitial fluid. So everybody goes, interstitial fluid. Why wouldn't we get it from, right, the blood source, right, from where we check our blood sugars, right, the blood vessels? When it's measuring interstitial fluid, if you can see here, do you see on the bottom where it says BG meter measures the glucose in the blood? And do you see how the blood is leaving the bloodstream and going into the interstitial fluid? This, just to explain it to you, you know, when I was explained it to me, someone explained it to me as a train, right? They said if your blood sugar was a train, right, the front of the train, right, the main function, the main part of the train would be your blood vessel. So you're going to see the number change here in your bloodstream, right, on a blood sugar check with finger stick, before you would see the sugar change in the interstitial fluid. That being said, oftentimes people who have great rises or drops in their blood sugar, the transmitter is on a lag, right? So remember, right, the front of the train, that's your blood sugar. The back of the train or the middle of the train, that's this interstitial fluid. So there is a lag time with how quickly we see the real-time blood sugar change. So oftentimes people that have settings on their sensors or CGM devices to alert them when we're starting to trend high or low, they set them a little bit higher. You know, some people, instead of saying, well, don't alert me at 70, alert me at 80, because I know there's a lag. Some of these sensors also will tell us when they start trending. If the sensor notices, hey, we're on the way down and we've been on the way down for the last 30 minutes and now we're getting into that range which might be too low, we certainly want to do something and act quick. So the CGM, right, provides real-time data right then and there. It also shows retrospective glucose information to the parents, the students, the healthcare provider, right? They can take all this data that's been graphed out over the last couple of days, plug it into the computer system, and you can start seeing trends. So this obviously will uncover undetected hypoglycemia. It can just give a lot of information to our students, our families, the nurse, and certainly their healthcare provider, so they can make adjustments accordingly. Alarms, right? Most of the CGM systems that are used in the pediatric population or adolescent population, especially those with type 1 diabetes, are using the systems that will alarm. I know everybody's seen the commercial for that Freestyle Libre, right? The Freestyle Libre basically will show us what the average blood sugar is only when we scan it. So the system's only as good as how often you're going to swipe the reader against the arm or the sensor and transmitter. So again, it's not constantly feeding the information. It's not going to alarm for you. It's just going to, instead of doing a finger stick, that system will tell you right then and there what your blood sugar is. Let's see. So CGM data, this says it should not be used to make treatment decisions, right, unless specifically stated in the DMMP. So different systems have met the FDA requirements differently. But either way, here we go. If you are questioning whether or not this information is real, certainly perform a blood sugar check. The Dexcom system, the G5 and G6, those are both approved by the FDA to make decisions, treatment decisions, for those 2 years old and above. I would just say, always have a glucometer in the school. You certainly don't want to be guessing or questioning whether or not that data is true on the CGM system. Again, what can make the CGM system not read as great for us? There's many of things out there. I'll just go, sorry. There are many things out there that can cause our CGM system not to work as correctly. So what can these things be? Hang on one sec, sorry. I just kind of skipped a little bit. No, didn't. Okay, well, yeah, this is it, I'm sorry. So CGMs can be used to make treatment decisions. Students who take acetaminophen, Tylenol, can sometimes throw off the data. Students who are stacking insulin, meaning they've taken bolus doses within 2 hours of each other, this is going to throw off the data. So there's so many things that can throw off the data on a CGM device. You want to make sure if you are using that device that you are completely following the FDA guidelines. Because there's so many things that can throw off that data and now make that data no longer real time. general guidelines for each student, right? CGM values may be used to make decisions on meals. Hypoglycemia, if the student feels low or the CGM shows a value less than 80, right, we probably should be checking on the blood sugar, the glucometer with their finger stick. If the student's blood sugar says it's low on the CGM, but they're not symptomatic, they're walking, talking, everything's fine, you might want to check it again. Let's see, hyperglycemia highs, right? Again, if we're going to give this patient insulin, we might want to just double check and make sure that that reading is quite accurate. So CGM supplies at school, right? Sensor placement does require training, and it is generally done at home. If the parent or guardian wants to keep supplies, CGM supplies at school, they need all the supplies listed here. So they need the receiver, they need the transmitter, the sensors, alcohol wipes, skin preps, the inserter, if they use one, otherwise it can be manually inserted. And obviously we want to know the manufacturer's manual alarm. In cases where the sensor falls off, right, maybe the kid goes to gym, they get sweaty, it falls off. What do we want to do? We want to put it in a place, generally speaking, I would say a place that is listed in that diabetes medical management plan. Why? We lose these things in the hospital all the time too, and they do cost a couple $100. So nobody wants to be responsible for that. Certainly, if they have a CGM, just list on your diabetes medical management plan where you're going to place it if it does get lost. It does require training. Some students can independently, apply the sensor, the CGM system to themselves, and certainly if you feel comfortable and they feel comfortable, we would obviously want you to do that. Next slides, we're talking about insulin pumps, right? I'm sure many of you have seen insulin pumps, right? They're the battery-operated device. They have a reservoir filled with insulin. There's a computer chip controlling it. It's worn constantly 24 hours a day, and it uses that Humalog, Novolog, or Apidra. And what it does is we're basically trying to do what the body does. Insulin pump locations are the same spots where we're giving our insulin injections, right? Subcutaneous tissue, backside of the arm, the buttocks, the upper and outer thighs, and the belly. Insulin pump delivers both basal and bolus rates. They're set by the user, which is basically determined by the endocrinologist, right? The endocrinologist is the one making these settings. A person that begins pump therapy meets their diabetes educator, their endocrinologist, and this is set up. And this is set up, the setup of them starting a pump is like 5 hours. And this is after they've watched plenty of videos. So again, don't feel intimidated if you're not sure exactly how to use it. And also know that there are a lot of insulin pump reps out there who do come to schools to do one-on-one training with you. So certainly, reach out to the parent if the patient is wearing a pump and say, who's the rep you used? Is there any way that I could talk to them or have them come in and do a quick, 30-minute thing? I know with COVID, maybe they could do a Zoom class or something with you just to help make you feel a little bit more comfortable. Basal rates, that's our background insulin, right? This mimics what the pancreas is doing. It works much like Lantus, right, or NPH. So basically we give the shot, it doesn't, it works, and it constantly is helping keep the blood sugars down, but it's not making the blood sugars come down very quickly. So our basal rate, if you look here, it shows you the difference between an insulin pump, right? Remember, insulin pump is using rapid acting insulin. And if you see on the top left, it shows you different settings. So this one from midnight to 3:30 a.m., the patient's receiving a unit of fast acting insulin every hour. From 3:30 to 9 a.m., we're getting 1.075 units an hour. So this is really fine tuning. And you can kind of understand it by, if you look at the Lantus below, The Lantus, right, that long-acting insulin, that's our basal insulin there too. Once it gets in the system, it basically stays steady at the same rate until it's out of the system again. Here with an insulin pump, we're able to fine tune and like we said, mimic what the body does. These are just a couple pictures of insulin pumps. The one most people use are the tube system that I talked about. Below that is a tubeless system, the Omnipod. That system, it basically has like a remote control, like you'll see in this woman's hand on the left-hand side. And the insulin is actually inside that pod. So it's a bit thicker than, you know, the tubing system. But a lot of people do like that. And again, these can be worn anywhere, the backside of the arm, the belly, the buttocks, the thighs. This last picture just shows you the CGM system working alongside the insulin pump. Carbohydrate ratios, right? Every person responds to insulin differently. So we want to make sure that we are dosing appropriately. Every person's completely different. You know, one person could have a carbohydrate ratio where 1 unit will cover 15 grams of carbohydrate, where a small child, 1/10 of a unit might cover 15 grams of carbohydrate. So we want to make sure that we are certainly have all these ratios listed in our diabetes medical management plan. For use later. Oftentimes these insulin pumps are fed the information and make the adjustments itself. They call it the wizard or the calculator. So when you punch in this information, you know, what the blood sugar is and how many carbohydrates, the insulin pump actually does the math for you. So we talked about that basal insulin. We're talking about corrective insulin or a sensitivity factor, right? So sensitivity is basically how much 1 unit of rapid acting insulin will lower your sugar in the next 2 to 4 hours, right? As long as that fast acting insulin is in your body. Your target blood sugar is the number we like to be. Most students, I believe, have a target of around 120, but every person's different. And this is just important to know. The lower the target is, the more susceptible you are to having a low blood sugar. So certainly someone who does not have great control diabetes, we don't want to make their target 90 or 80, because guess what? If we're going to that target number, we're more likely then to wind up having a low blood sugar. This just talks about dosing with the insulin pump. Right now I'm going to give you kind of like a little calculation to help you understand, because I know we only have about 5 minutes left and I want to leave a little bit of time for Q&A. So putting it together, right, an insulin pump. And this is actually even how we do our carb counting for patients who take Lantus and the fast-acting insulin when we're using this for carb counting. So what do we do, right? We have to add up the total amount of grams of carbohydrate that we're going to eat at that time and divide it by our insulin to carbohydrate ratio. So an example, you're going to eat 45 grams of carbohydrate. Your ratio is 1 unit for every 15 grams. Simply enough, what we're going to do is divide the 45 grams of carbohydrate by 15 and thus administer, right? 15 goes into 45 3 times. We're going to give 3 units of insulin to cover the carbohydrate. If we then, right, let's pretend it's lunchtime, that's what we're eating for lunch, 45 grams, we also want to fix the high blood sugar. So we also want to subtract your target blood sugar from your current glucose, right? So let's say lunchtime, 45 grams of carbohydrate and our blood sugar is 190. We take that 190, subtract that target blood sugar from it, right? And then we want to divide that by the correction factor, right? So 190 minus 120 is 70. 70 divided by 35 is going to give us 2 units of insulin just to get that blood sugar down to normal, right? So when we combine the two, right, we're going to fix that high blood sugar. We're going to cover the food they're eating. We're going to give 5 units of insulin. So it's pretty clever. It's pretty cool. And again, most of the pumps already have all this information logged into them. So you're kind of just double checking and making sure that it does make sense. The last part, again, just talks about how the glucose monitors actually, the CGM devices work with the insulin pumps. They did come out with these hybrid closed loop systems about 4 years ago, where the sensor CGM data is then fed into the insulin pump, and the insulin pump is then doing a few different things. There's 2 big pumps on the market right now. One of them actually will give micro boluses, so little tiny amounts of insulin every 5 minutes if it senses your blood sugars going up. So we still need to, no matter what pump it is and CGM system we're using together, we want to make sure that that the pump is feeding, obviously, the correct information. If we're taking acetaminophen or something else like that, we certainly don't want to use this closed loop system. But when we do have this closed loop system, we always need to make sure we still know how to carbohydrate. We're still going to have to take insulin every time we're eating, because the pump doesn't recognize that we're eating. But after we've eaten and after we've given ourselves the bolus for the food, 2 hours later, if your pump says, hey, why are we still high? We should be back down to normal. That's when it starts firing off these micro boluses, which is pretty cool. Again, that's one version of a pump. Another version of a pump also will notice that the blood sugars are trending low. And what it does is it suspends the pump or stops the basal rates from going in. So technology has come very far. It's out there, it's available for us. Hopefully your students are using it. And let me just see, I'm just trying to get me back on the screen. So here is Q&A, new share. Oh, I don't see my face. So let's see. I know, are we just over? We're 1 minute behind. I see some Q&A here. I'm just gonna read through them. So it says, my name is Carol. I'm a nurse coordinator, and I've signed up through, but I didn't receive, oh no, sorry. Okay, can you go over stacking again with the Dexcom 6 and the Omnipod system? So stacking insulin. Stacking is something that we can do whether we're on an insulin pump or not, but most people who stack are generally insulin pump patients. Insulin pump patients have the ability, right, to take insulin at any time without having to do more than punch a button. So stacking of insulin is really anyone who's using rapid-acting insulin, Novolog, Humalog, or even Apidra. So any of those insulins can be stacked, and we want to make sure, because the insulins work so quickly, that we're not giving them on top of one another. So again, we generally said after 2 hours, that fast-acting insulin's out of the body, but it's still lingering a little bit. So in 2 hours, if we've already given a bolus, let's say we had lunch, and right after lunch, 30 minutes later, we decide I'm a high school student, I'm gonna have a giant chocolate chip cookie, okay? And they take insulin again. If they take those 2 insulins together, oftentimes, the pump does not take into account, hey, we already have insulin on board, we don't need all this extra insulin. So, you know, I see it here in the hospital with patients who do not have insulin pumps, where, you know, they said, oh, well, I had breakfast, and then I decided I wanted an early morning snack, and then they wind up coming in here because they fell on the ground and can't figure out why they had a low blood sugar. It's just eating meals too closely together and taking that rapid-acting insulin too quickly. Does that make sense? Can everybody hear me?
Yes, but I believe they're muted.
Okay, okay. All right, so I don't see any more questions. Wait a sec, let me just say, yeah, that was the chat box. Does anyone else have any questions? Okay, I apologize. I'm not very computer savvy, and and this is my first time giving one of these. So I'm glad you bared with me. And if no one else has any questions, I believe Debbie Sandra said she would just get this information over to you with all the attendees' names.
Okay, thank you. Thank you for all
Okay.
attending. And thank you, Jenna, for presenting to us today. We appreciate all
Okay,
the
wonderful.
information. Bye-bye.
Great. Thank you. Bye-bye.